Hello everyone, welcome to Women's Health with the Listening Midwife. Today I've got with me Helena.
Hi.
So Helena, what are we going to talk about today?
Congenital conditions. My little one was born with a congenital health defect. So
today we're focusing more on what Helena's been through, and that is having her little one Indigo, who's probably going to come through because she's with us today for the interview, and she had congenital diaphragmatic hernia. I said that right, didn't I?
Yes.
It's such a long word, but so just to talk a little bit about what that is. Well, actually, let's hear it from you. What is congenital diaphragmatic hernia?
I'd never heard of the condition before. We got told about it in our 20-week scan, but basically there's a hole in the diaphragm that just hasn't formed properly during sort of development, and it allows the contents of the stomach into the chest. So her intestines and her stomach were in her chest space rather than in her abdomen where it's supposed to be, which meant her poor little lung was squished and her heart was moved across. So she was rather poorly.
Yeah. Okay. How old is she now?
18 months.
18 months. So, and she's pottering around, she's living her best life, and
big and bossy.
So we'll talk about what that has meant for her through the pregnancy and her, the first few months of life and up until this point as well. Let's start with a little bit about you. Tell us a little bit about you.
So I work almost alongside you at Lister. I'm in the early pregnancy unit at university doing my final bit of my nursing degree. So hopefully I'll be fully fledged at some point soon. Indigo is my second daughter. I have an older daughter who is 6, going on 16. Joys of
I can relate
to attitude. Pre-ordering a straight jacket at this point, but yes, I've got my 2 lovely ladies keeping me on my toes.
Very busy. Yeah. So you say you had your older daughter who's 6. What was that sort of briefly? What was that pregnancy like?
Not amazing. I had an unusual skin reaction to pregnancy. They couldn't decide if it was pup or atopic eruption.
Oh, wow.
But I describe it as looking rather like a burns victim.
Oh, blimey.
From around 12 weeks until she popped out all over my sort of face, torso and everything. It was rather ugly looking. My poor patients were looking at me like, should you be looking after me or should you be the patient? Pregnancy wise, it was fairly okay. Not the best delivery. I had a very long induction and then ended up with a category 2 sort of emergency C-section, and then developed sepsis.
Oh dear.
So all in all, there's a reason there was a large gap. Because I wasn't ready to do it again for a while.
You needed the time to recover. Yeah, we're talking about your big sister.
Your big sister? Where's your hair? What are you doing? Hey? But I recovered well from the section. I managed to get breastfeeding sort of going really, really well. So very proud of that.
And did the skin condition resolve?
Literally within 12 hours of her being out. It was weird.
So really pregnancy induced, and pregnancy was the catalyst for that
around 12 weeks. So when the placenta kicks in, it was assumed that it was just the hormones associated with that. My body went, oh, what is this? Yes. So I was very worried about getting pregnant with this one in case it happened again. Fortunately, it didn't.
Always good.
But yes, rather traumatizing for everyone now to look at me. Okay. But she's good.
Then getting pregnant again.
Yes.
After feeling like I can do it.
I can do it again. I can deal with the skin. Enough people around me are willing to deal with the horror. Should it happen again. It felt very different second time. Working in early pregnancy, working in women's health, I'm sure you can appreciate we very much advocate that women's instinct is normally on point. If you know something's wrong, you need to tell someone, because actually quite often something is wrong. And given my history with Luna, given my pre-existing sort of anxiety, I got myself referred back to the mental health team early, just as a precaution. And then from about sort of 7 weeks, I was saying something's not right. I don't feel bonded. I don't feel, I've got this horrible feeling in my gut that something's not right. And everyone was saying, no, it's fine. You're just worried. Second baby, you've got enough on your plate.
And everyone could sort of understand that you would be more anxious because of everything you've been through. So
and working in women's health.
Working with women's health does make us a little bit more...
hypochondriac.
Terrified of everything. And so it's interesting because as much as we were there for you, we also sort of, without knowing or meaning to, probably sort of played down your feelings and emotions, didn't we?
Careful. Where are you going? Yes. No, it was hard, especially because we didn't know that anything was wrong. But then I had quite torrential bleeding earlier on in the pregnancy. I staff perks, did manage to get seen by my colleagues, which was not the best moment because obviously you're never fully prepared.
No.
Or clean or shaved or wearing a bra.
We don't actually care about. Just to put it out there, like I think that's a personal feeling to want to always feel prepared, like your lady bits are very well put together and vajazzled and whatever. But as healthcare professionals, we really just don't care or notice. Actually, quite frankly, I think the one thing I always say is we notice like smelly feet because when we examine you take your feet, your shoes off usually, and you get into position, and women are like, "Oh, I haven't shaved, I haven't done that," and I'm like, "It's your socks we're gonna notice, hun. It's your feet." So
stinky feet,
as long as they're clean, like you're right, we're fine.
Yeah, so bless them. I had no bra on. I had not shaved. I had a conditioning mask in my hair. I was sex on legs at that point. But yes, it was terrifying. Having worked in EPU for as long as I have never seen that amount of bleeding with a live baby. I assumed.
How many weeks was this?
9 weeks and 6 days.
Okay.
And having dealt with a lot of bleeding in the past, I'm estimating about 1 litre.
Oh, wow.
It was like a tap. It was terrifying, soaked in my clothes.
Oh.
Awful. But yes, my fabulous colleagues scanned me, looked after me, serial scanning throughout pregnancy, progesterone from 10 weeks through to 24 weeks.
So if you've had lots of episodes of bleeding in pregnancy, in that early pregnancy part, we can offer a medication called progesterone, which is an internal pessary. So it goes into the vagina or sometimes into the bottom. And it works locally in that area to just try and calm the womb and keep the pregnancy as much as possible. So that is something that if you do have recurrent bleeding, if you haven't been offered it, you can ask your clinicians if that is appropriate for you. It may not be appropriate for everyone, but do ask because actually it's something that you should know about and you can discuss to see if it's right for you.
Yeah. But yes, I had a good few quite significant bleeds. And obviously being Rhesus negative.
Oh gosh.
Lots of nice stabby anti-D injections.
Okay, so she's giving us lots today. So Rhesus negative, this is this is a type of your blood group. So you'll be A, B, you'll be O, and you'll be positive or negative. So if you're Rhesus negative, this means that we usually offer women and what's called anti-D injections if they've had any kind of bleeding or bumps or trips or falls during their pregnancy to try and avoid their bodies creating antibodies that can affect future pregnancies. So that's something to bear in mind. If you found out during your pregnancy that you're Rhesus negative, then do bear in mind that if you have any bumps or trips or falls or bleeds, then you need to come in and we need to offer you this anti-D injection to reduce your risk of what's called a sensitizing event in subsequent pregnancies where you make antibodies. How did you then find out about Indy's congenital or diaphragmatic hernia? I'm just going to keep saying it because it's good to practice those words.
So we went to our 20-week scan and we had our anomaly sort of big scan in the middle. And having seen enough pregnancy scans throughout my time in the early pregnancy unit, I was, commenting along, seeing the scan as our lovely Anna was scanning me. And she kept hovering over the diaphragm. And I was like, oh, is that the diaphragm? I was like, very proud of myself. I spotted the line on the line.
Yeah.
And it was and didn't say anything, came back. And then at the end, she was like, right, I've not managed to get good measurements of the heart because in hindsight, it wasn't appropriately positioned. There was stuff in the way. But she said, I think baby's got a hernia. I was like, okay. But she said, oh, we're gonna try and get hold of the fetal medicine team and see if they can sort of have a look at you, scan you again, and confirm or say no, you're not seeing what you think you're seeing. I was like, okay, that's fine. And at the time I was like, okay, it's all right. I was even texting my mum in the waiting room, who was looking after my eldest, to say, look, scan's a bit delayed, waiting for a second opinion. Hello. Because they think maybe he's got a hernia, and my mum's already panicking, going, oh my god, what's going on?
Yep.
One of my wonderful colleagues and friends, consultant, was like, I'm coming now. She didn't really have capacity, but she's like, no, I'm coming now. And she scanned me, and the fetal medicine midwife also came down, Ali. I looked at Ali's face and I was like, oh, this is more serious than just a little hernia, isn't it, at this point? But then I think halfway through the scan, seeing Mona's expression, seeing how serious she was concentrating, I clicked. It just suddenly, like, I had the penny drop moment, and I was crying my eyes out during the scan. She said, no, this is a diaphragmatic hernia. The fact that they'd spotted it at 20 weeks, they were very concerned, because if it's visible at 20 weeks and the baby's a bit smaller, the thought about how severe it is also there. So they said, right, we need to refer you to UCLH to get their opinion. That's where we refer our sort of significant fetal medicine cases. Obviously they'll see you as soon as they can.
So CDH, that's one of the conditions they look for as part of the anomaly scans. The anomaly scans, a scan usually have between sort of 19 and 21 weeks, and they're looking for a series of conditions such as congenital diaphragmatic hernia. And actually, when you have one of those conditions, usually they can be picked up on scan. Not every condition can be picked up on scan, but this is one of the conditions they're looking out for as they look through the baby's organs and structure. They look at the long bones, they look at different views of the heart, they look at the stomach, the bladder, all of the organs, all the internal organs, the kidneys, so they can usually identify if there's an issue there. And CDH is one of those conditions that they can identify. And if they do identify it, then they refer you to what's called a tertiary unit. So this is one of the bigger hospitals that have the expertise to be able to look into, do more detailed assessments and scans. And then based on the findings, they can then make a plan of care about what your options are during your pregnancy, whether it's you continuing your pregnancy, looking at what the prognosis is, looking if there are any treatments that need to happen while you're still pregnant or soon after the birth. They make all of those plans. And for example, UCLH is linked with Great Ormond Street quite closely, even in a location. They're probably about a couple of miles from each other, aren't they? So generally, they will have really good links with women who have these conditions, and sometimes women will go there to have their babies. Other tertiary units up and down the country will have other specialist centres that they link in with as well to make those detailed plans. Yeah. So UCLH then. Yeah.
They confirmed, yes, definitely is. And then there's a barrage of other tests that they then wanted to do. So I had to have an amniocentesis.
And do you know what? So why were they offering you more testing?
They wanted to do the amnio to confirm. So they said if a child has a CDH, sort of, the prognosis is better if they don't also have an associated chromosomal issue. There were no signs or any concerns on any of her scans to show that there could be, such as Down syndrome.
That you had, the Down syndrome screening.
Yeah, there was no signs of anything like that, but some conditions put them at higher risk of having a diaphragmatic hernia.
Yes.
So because they'd found one, they wanted to rule out other chromosomal factors, because then that would definitely affect the prognosis, because obviously just a structural defect is hard enough.
Yes.
You then add a congenital chromosomal issue that then comes with its own other problems. You know, like Down syndrome have cardiac issues.
Yes.
So they wanted to rule out anything chromosomal to give them a better picture. I had to have an MRI with her still in utero. That was not fun. Multiple scans. She had to have an echocardiogram done. I felt like a human sort of guinea pig. I really struggled. I felt, it's weird, I felt very sort of like I was just the incubator. And understandably, though, everybody was very, very worried about her. They wanted to check that she was okay. But I was literally being poked, prodded, scanned left, right, centre, up, down, just constantly being sort of
you remember that?
Poked and prodded. And I really struggled. I felt completely disconnected. The mental health team were worried. I was going to be giving I was offered sessions to help with bonding after she was born, because they were concerned that I was not bonding with her, because I was, maybe subconsciously protecting myself, because actually if she didn't survive, it would be easier if I hadn't bonded. Things like that. But towards the end, I was being scanned at UCLH every 2 weeks. It would have been more frequent had I lived closer, but they agreed that the week in the middle I could be scanned at Lister. But I was being scanned every week at one point for growth scans, fluid measurements, checking on her growth, and all those kinds of things.
And up to a point, Helena was still working, and being someone who works in the NHS, like that, what did that do to you? I mean, your mental health, I can only imagine, but also trying to balance life with, your daughter at the time and your partner, your family, this baby that you're growing, and not sort of having the emotional capacity really to bond with, but also trying to work. What was going on there?
I mean, I eventually ended up going off sick because I couldn't do it, but I literally felt like I was in hospital at every point of every day. Either I was working or in a hospital for myself. I don't know how I didn't actually have a breakdown, but I think I was very, very close.
I imagine.
But yes, it was not fun. And obviously there's the expense of having to travel into London. We ended up driving all the time rather than getting the train, because the train's extortionate. But it's fuel, it's parking, it's congestion charge and ULEZ, because obviously it's central. So it's every charge that the government can chuck at you. And
and this is it, as a parent who wants to do everything for your unborn baby, your family, those are things that you just do. You don't go, oh, it's too expensive for me to get into London, or, and for some people it is just too much. And we've had to have those conversations. I know I sit with my colleagues in fetal medicine, and sometimes the families are like, we've got several kids. We don't have the capacity or the finances to do that. So do look into government grants, do ask the hospital about opportunities for financial support, because there are some of those, not many, and maybe not as much as we'd like, but they can cover some of those expenses to ensure that you are able to do what you need to do for the health of your pregnancy and for yourself.
So there is an actual charity, CDH UK.
Yes.
They also have
access to
grants that you can apply for. For financial aid for things like that as well. So if
CDH UK. So check out if you are in that position, you have a baby who's been diagnosed with congenital diaphragmatic hernia. Do check out the CDH UK website. They do have offers of grants and ways to support, and also just being connected to people who may be going through what you're going through can help as well. So definitely don't do this alone. This is too big to do alone.
Fortunately, she came out kicking and screaming, surgery really quickly and everything, and has done really well. But there are some children who come out and they have really bad issues. We were sort of counselled to expect anything from 6 weeks to 6 months up to a year in hospital post-delivery before they can get her home. So we were like, oh my God, we both have careers, we both have we have an older child. What the hell are we going to do? They did talk to me about the in utero surgery that can be done with CDH. But because of all the torrential bleeding, they didn't want to touch my uterus, understandably. But B, they didn't think it was quite severe enough that the benefits would outweigh the risks. Because obviously doing the fetal surgery, much higher risk of preterm labour. And unless it's one of the most severe cases, they don't like to do it. Because actually keeping her cooking for as long as possible is the best thing.
option if possible. And there are those risks when you do have congenital abnormalities, conditions, fetal conditions, that can increase your risk of preterm labor as well. So bearing that in mind, because you have to mentally be prepared that my baby might not stay in there until the due date. And most times actually with these kind of conditions, we like to move that due date or your birth, the date of birth earlier than your due date. Did they talk to you about how they wanted you to birth? I know you'd had a cesarean section with Luna. So what did they discuss all the options, or was it sort of leaning more towards, let's just have a planned cesarean section where we can control as many factors as possible?
Yeah, I mean, I think I had already mentally decided I wanted to have an elective because of how terribly it had gone with Luna. But then getting her prognosis, like her diagnosis, I was very sort of set I wanted a cesarean, and they were quite keen to stick with my plan. They didn't want to sway me otherwise. The plan was obviously that I needed to be delivering at UCLH, because obviously that's the tertiary centre, who geographically, above all else, are then able to transfer to Great Ormond Street much easier. But they've obviously got the very good, like very skilled neonatal team that can intubate immediately, all those kinds of things.
And they're used to seeing these conditions as well, because it happens that we're in the hospital that we work in, it's a level 2 neonatal unit, so they're very good at looking after babies who are over 27 weeks gestation and who don't have significant congenital abnormalities. So anything that they find that is that complicated, it's always better to deliver in a tertiary unit, but that doesn't mean that if you deliver in a level 2 neonatal unit, your baby's going to die. That's not what it means. It just means that they will stabilize baby as quickly as possible. They will arrange with the neonatal transfer team, as called PANDA, and they will get that baby to the tertiary unit as quickly as possible. And the neonatal transport team are made up of neonatal consultants with a lot of expertise as well. So they will be part of that team that are helping to transfer baby. So don't panic, because sometimes women will come in much earlier because they've started to have bleeding or something, and we have to facilitate the birth much sooner than planned and not in the tertiary centre, but they are able to stabilise your baby and give baby the best chance. So don't panic if you do find yourself in a level 2 unit having had a plan to deliver in a level 3 unit. They will liaise with the hospital, the tertiary unit, and they will make sure that your baby gets the best care.
They said if I happen to go into labour rather than fighting the traffic into London, they'll go to Lister. They can deal with, and then we'll transfer out. But the planned section was at UCLH. They did arrange for me to go to Great Ormond Street and have a tour.
Oh, amazing.
And the NICU. They got some of the surgical team at Great Ormond Street to come and chat to me and Sam and discuss everything, so we knew roughly what to expect. It was good.
My question would be for women who are going through this experience or similar experience, because might not necessarily be congenital diaphragmatic hernia, but it might be one of the other conditions. It might be that if baby's been diagnosed with Down syndrome, for example, and if you've chosen to continue with the pregnancy, then what did you find useful from healthcare professionals, and what did you not find useful from healthcare professionals?
I mean, one thing that I really found problematic is, so obviously Lister are not used to such significant congenital deformities because they refer to UCLH. So I found it very difficult, because I was going to the appointments with the fetal medicine team there, who were fantastic. They were so supportive. They couldn't do more for me. But obviously they were very, oh my God, this is really bad. And they were very worried. The tone they were setting was very, we need to be prepared, we need panic, we need to
so slight panic and not as much reassurance just because of the gravity of it.
But then when I went to UCLH, who obviously do see, not very many because it's not that common of a condition, but they do see more a lot of CDH babies, I suppose they were less worried, but to me it came across as almost complacent. And it's fine. It's like, okay, but this is not fine. I appreciate you see these more often than most, but this is my baby. And I am terrified she's going to die. You're not reassuring me. You're making me feel like oh, it's fine. And it came across a bit slapdash at times. The biggest thing I would say is you need to advocate. I didn't have a named consultant.
Okay.
I saw a different doctor every appointment. I had issues because different hospitals use different measurements. 1 minute Lister are telling me that I've got quite significant polyhydramnios, but UCLH are using a different measurement. They go, oh, it's not that bad. I know it's subjective because obviously she could move and the deepest ball could be different. I know it's an at the point measurement, but it's the different.
Yeah, it doesn't help.
There was no sort of uniformity or consistency to the planning. But I put my foot down and I said to the fantastic Ali,
shout out Ali Patarchek,
we love you,
our wonderful medicine midwives.
I said, look, I need you to help me. And she did. She phoned the head midwife of the fetal medicine team at UCLH, and they did go, hang on, okay, yeah, we're sorry, we need to sort this. But yeah, you have to advocate not only for you but for your baby, because they can't talk, they can't communicate. You are their advocate. You're their voice. If you have worries, no matter how much of a pain in the bum you think you're being, you say something. I was under the reduced movement pathway with Luna, probably due to paranoia.
Doesn't matter why, if you are not 100% sure that your baby is moving, you need to be
100%. And surprise, surprise, I was under that pathway with Indigo as well. Probably due to the poly, because I have to admit I was having scans and I was watching her practically doing a can. Couldn't feel a thing because obviously she had an Olympic-sized swimming pool to be bobbing around in.
Space.
Yes,
you did have lots of space.
You did, but you need to be your baby's voice, because
I love that.
No one else is going to be. You have to. And if you have worries, if you don't feel you've been appropriately reassured or communicated to, or I know what you've told me, but can we break it down in a slightly less medical term? You've got to say it. Doctors are very good and the team are fantastic, both Lister and UCLH and even Great Ormond Street, but they're doctors. We love them.
We have our own lingo, so but we like big words and abbreviations. So it is okay for you to say, I need that to be clarified for me. Can you break that down, make it a bit simpler so I can understand it? Or can one of your colleagues just explain that to me slightly differently? I'm struggling to understand that. We know about, some people, English might not be their first language. You might have some people who are neurodivergent. So actually, it's okay to just say, I need to understand that a little bit clearly, because you're fighting for your baby, you're fighting for yourself, and you are allowed to do that.
Yeah, definitely.
Yeah. So with CDH, all babies will need surgery after birth to repair the hernia, the hole in the diaphragm. So because of the underdevelopment of the lungs, all CDH babies will need some element of respiratory support. This is breathing support. So, it might be they need to be intubated straight away because their lungs are underdeveloped. So they need extra help at the birth. So can you just tell us a little bit about what that experience was like for Indy around the time of the birth?
So it went pear-shaped again.
Oh gosh, okay, go ahead.
Add another little. So my fabulous elective cesarean, I went in at 3:05.
Strolled into theatre.
Strolled in, happy as Larry, whopping great cannula in one hand. Proceeded to have my spinal, which went beautifully, and then the very, very easy, normally not problematic at all, catheterization didn't happen. I didn't realise this was an issue until they were like, we need to get urology to come in and have a look. They've come running over. They attempted and couldn't.
And spinals they don't last forever. So you're on the clock really, because you've got about 6 hours before you're regaining full sensation. It's usually within a couple of hours women start to regain sensation. So you've got a short window of time to kind of do your surgery, get women into recovery, get them stabilized. So time is ticking as they're unable to catheterize you.
Yes. Unbeknownst to me, because obviously didn't have a watch, about 2.5 hours later, they still couldn't catheterize. In the end, they said, look, it's been a couple of hours, your spinal is probably going to be getting patchy. We need to do a suprapubic catheter.
Wow.
So that is a catheter that is rooted through the outside. So they made a cut in my one's pubis.
Right on the pubic bone.
Right on the front.
Right on the front there.
Where your knickers sit, like on the front. And obviously the tube that went directly into my bladder.
Wow.
But yes, my spinal was probably going to be getting patchy. So they said, look, okay, we're going to do a GA. So I had to be put to sleep. They really don't like doing GA sections because obviously anything that goes to me goes to her.
Baby. Yes.
And a lot of sort of sedative medications then reduces respiratory drive. So
we didn't need any more respiratory drama for baby.
Didn't.
We already were starting on the back foot with that. So general anaesthetic can make babies quite drowsy, and it can affect their breathing. So when we do a general anaesthetic to put women to sleep, we move very quickly to get the baby out because we know of the impact that it can have on the baby. So sometimes it's absolutely necessary. It sounded like it was absolutely necessary in your case. Some women have deformities of their spine, so actually they can't have a spinal or an epidural in their backs, and they have to be put to sleep because that's the only way to ensure that they are pain-free during the surgery.
Or if it's like an absolute cat one.
Absolute emergency where it's, because the spinal will take sort of about 20 minutes to do. Whereas if we think your baby needs to be born imminently within minutes, putting you to sleep can happen within minutes. And so actually in dire emergencies, we will put you to sleep and get baby out as quickly as possible. So yeah.
I went in just after 3 and she was born at about 6:30.
Oh, wow.
So
elective procedures usually take about an hour and a half in total. Once you're anaesthetized, like usually with a good working spinal, from the knife to the skin of the womb, and to baby being born, it's usually within 5 minutes. If you've had lots of other surgeries or previous cesareans, it can be a bit longer to get through all the scar tissue. But normally, your baby's out within 5 minutes of the surgery starting, and then it's all just repairing the wound, which takes about 45 minutes, barring any complications. So 3 hours later, they then start the surgery and get baby out.
I woke up hours later. I think it was bordering 9-10 o'clock at night, because obviously it takes a long time to come around from a general anaesthetic. And obviously she was not there. She was in intensive care. So I was in a postnatal delivery area, hearing lots of bawling newborns, and I have no baby. So I was a wreck. Eventually I managed to cry at the right person, who agreed to put me in a wheelchair so Sam could wheel me to intensive care. Bless him, he had taken photos for me. So I had at least seen her, but I hadn't seen her properly. From what I gathered, she came out completely floppy, no respiratory drive at all. So they obviously intubated immediately. And put an NG tube in, obviously because of the pressure in the stomach and everything. So they like to so they will usually intubate, which is to put a tube into babies through to the lungs, so that they can help with breathing support. They also like to put a tube down to the stomach to keep the stomach empty, because we need to keep everything as flat as possible, give the lungs as much room as possible as well. So that's a nasogastric tube that goes into the stomach. So they didn't feed her, obviously pre-surgery, because they needed the stomach empty. So she was on TPN, so IV nutrition. I had to somehow attempt to start expressing, which, if anyone's had a C-section will tell you, the post-delivery contractions associated with breastfeeding are sometimes worse than the actual section itself.
Especially the more babies you have. Second onwards, they're quite intense, those birth after pains, and they're oxytocin from expressing or breastfeeding can cause those contraction pains, because that's what it does. It releases oxytocin, and that squeezes the womb.
So it's good, because obviously it means it's
doing the
contracting
job.
down as it's supposed to. It's but fortunately I had successfully breastfed my eldest for quite a while, so I was rather versed in expressing and etc. But yes, I turned into a full-blown dairy cow throughout our time in ICU. I think
it's been great.
I mean,
we can see her; she looks fantastic. So the boobs did a good job.
I mean, I think I got
shout out.
I think I got about 10 litres.
Oh wow!
In the end, she was never going to get through it all, bless her. But yes, so I obviously was trying to go and see her in intensive care. It's the hardest thing, especially if you've already had a little one.
Yeah.
To be able to touch her, but not hold her.
Yeah.
The most I could do was change a nappy.
Yeah.
But even then, you're so terrified because they're so fragile,
and
there's all these wires and tubes coming out of everywhere. You don't want to move them too much.
Yeah.
You know, all you want to do. Personally, I'm very tactile.
Yeah.
Anyone who sort of, my husband, bless him, if he tickles my back, I'm practically a puddle on the floor. I'm very tactile.
Yeah.
But I've always been very good at. I love stroking my children's head and their hair. Even now, my 6-year-old, if she's having a proper sort of, she's really poorly or she's really, really upset, if I sit there and stroke her hair, that really calms her down. So I went to do that with this one, and I've got the nurses saying, no, babies don't like that. Don't do that. And every motherly instinct that you have is almost being squashed by these nurses who have her best interest at heart. But, you know, you can't do anything. Everything that your body is telling you to do.
That skin to skin, those cuddles, that bonding, which is what we always tell women to do. If everything else fails, skin to skin, get them back down to their nappy and get skin to skin. And, you know, when you've got a poorly baby who's got tubes, you know, she's got a tube down the nose, she's got a tube down the throat, and
coming out of her belly button,
out of the belly button,
an umbilical line, catheter, everything.
Oh gosh,
she was just tubes and wires at that point. But so she came out and she was really good. Actually, they warned us that CDH babies tend to have pulmonary hypertension. So the pressure in the lungs, because everything is so squashed and compacted, puts a massive pressure on the heart. So they quite often need a lot of vasopressors and cardiac support. And actually, fortunately, she didn't. She was doing really, really well. She was sort of breathing well with the tube, barely any nitric needed. She was doing really, really well. So they managed to transfer her to Great Ormond Street on day 3. We had the terrifying ordeal of stabilising a baby for transfer. You think they're just going to unplug one machine, plug it into a portable machine, and they go, no, this was about an hour and a half, 2 hours of getting her ready, off of their machines onto the portable machines. Oh, we had an x-ray. I think the tubes moved. I was bawling my eyes out in the corner because obviously at one point
watching them doing all of that.
And at one point they were like, oh, I think we need to do this again. I think we need to stop. I think we need to do this tomorrow. And obviously I'm going, no, we need to go now. But that was about 3 in the afternoon. I don't think we got to Great Ormond Street till at least sort of 10, 11 at night,
which is only a couple of miles down the road, literally from UCLH.
But if you've ever been in London,
and
you've seen traffic, despite the fact that we were on twos and twos, full blown sirens going, we were stationary for quite a lot of it. But yes, we got to Great Ormond Street, and they immediately brought her up to Dolphin Ward, the neonatal intensive care unit. And that became our home.
How long was she there for?
So surgery was there to day 3. I think she was managed to be stepped down on day 15, which was incredible.
That is amazing.
She had her surgery the next day, and that was the longest wait of my life.
I can't imagine what it's like to be a mother with knowing your newborn is having surgery. I mean, it must just be, I can't imagine it actually.
No, it was hard enough when my eldest had grommets, and that was an hour. It was nothing. She was like 3. That was the longest wait of my life, but she had it and it was great. Then obviously it was the tedious, unending, gradually reducing steps. So they had to reduce the ventilation and then extubate.
It's just taking the breathing tube out.
And they did, chest drain first. So they removed the chest drain. So after surgery, they left a drain in situ to just stop the
build up of fluids.
Because obviously there's a space that's now no longer occupied by the stomach and intestines, and the lungs not filled it yet. So they were worried that she would, get a pneumothorax. Took the chest drain out, and within 6 hours she got a massive pneumothorax, so they had to
collapsed lung.
reinsert.
Yeah.
But that was one of the most terrifying moments of my life because she stopped breathing, even with the ventilator. They had to manually take over.
Oh, wow.
And she was she splinted her chest. When it's that, like, I can't breathe, they go rock solid, they can't breathe, the ventilator won't work for them, they were having to manually bag her to get her to breathe. And at that point I literally thought she was dying. Sorry, this makes me cry every time. Yeah. But yeah, if you've never been in an intensive care, be it adults, neonatal, or an acute hospital, or even a maternity, if you've never seen it, when they pull that crash bell, it's terrifying. People seem to actually walk out of walls when a crash bell gets pulled in an acute setting, like in maternity. When I had my emergency with Luna, I mean, there was a lot of gas and air, but I'm sure I saw somebody literally appear through a wall. You pull the crash bell,
they just descend.
People just arrive, I had it when my dad was, very poorly in Packworth. I pulled the crash bell, and within 10 seconds, there's 30 people. And as a parent, to not only see your baby possibly dying, to then almost but to almost be jostled out because they're having to be so sort of immediate with their care with her. I felt like a third party in my own child's life at that point. I was watching her die, and I wasn't even able to
do anything,
hold her or comfort her or anything. But yeah, she then was able to have the vagina moved. They extubated. I think I got my first cuddle when she was about 12 days old.
Wow.
But 12 days of not being able to actually hold. And every day, can I hold her? Oh, we'll see if we can do this, this, and this. Oh, she's still got the umbilical line in. We can't really do cuddles when there's an umbilical line. And just felt like every hurdle was impossible to get over. But we did it. And they stepped us down to Bedford because we live in Bedfordshire. But that was quite jarring, actually, because intensive care on its own, but let alone Great Ormond Street intensive care, which is the
extra intensive care.
There is a bay almost as big as this room just for her, with machines everywhere, one-to-one nursing 24 hours a day. It's amazing. To then be stepped down to Bedford, which is a level 3, I felt like we were in a cupboard. It was night and day, and I got really, really emotional because I was like, but she's too poorly. I can't have this. This is not enough.
The step down's the hardest part for NICU mummies who have been in tertiary level care. So going from having really intensive care from lots of people to then having and not necessarily needing it too. But you're so conditioned to having such a high level of care, and somebody who's always there just for your baby, to then having one nurse looking after 3-4 babies in a big bay, and you might press the call bell and it might take a little bit longer for someone to come rather than the nurse just being present for your baby. It's quite a challenge, and a lot of NICUs do have a repatriation family nurse who tries to kind of guide you back into smooth it through.
It was really scary.
It
was hard because, like I said, in my mind I was like, okay, but this is good because it means she doesn't need that acute level of care.
But you're really convincing your mind at that point.
She's going to die here. She's going to die. They don't know what they're doing.
And they do. They're very good. They're very good. But you're so conditioned to having such a high level of care that it makes it quite a hard transition.
But we were there for final sort of weaning off of the oxygen, and they were having to manage her withdrawal from the opiates because obviously they were giving a lot of sedatives and morphine and everything, so we did have a sort of a weaning plan of that, and to fully establish feeding. This is when my big balls and being a healthcare professional came into play, because once again I had to basically tell a consultant no. So she still had the NG tube in, and having never had a baby who was being topped up with NG foods while I was trying to establish breastfeeding, I found it really, really hard because they were like, okay, we're going to come in every 3 hours and we're going to top her up.
With your milk?
With my milk.
Yeah, okay.
But you need to feed her in the interim to make sure that she's feeding appropriately. I was like, okay, but babies don't, breastfed babies are not on a timer.
Yeah.
It's on demand. So she might feed every hour. She might not feed for 4 hours because she's had a really good sleep.
Yeah.
It's not, I can't time it.
Yeah.
And they just kept coming in and topping her up. And then understandably, she didn't want to feed because she was full.
Yeah.
And I know doctors, again, they're amazing, they're fantastic, but they, as much as they want women to breastfeed, it feels like they don't.
I think they
can't measure it.
Yeah, they want to control everything.
Control.
And that is the inherent nature of being a doctor, is that you want to control things. You want to control the progression of disease, avoiding of disease, or whatever it is.
You know, the calorific intake and everything like that.
Yeah.
The formula, but with breast.
With breast milk, it's very mother-led.
Yes.
And baby-led.
Baby-led, let's face it. It's not mother-led at all.
Actually. It's nothing to do with us.
Nothing to do with me.
We just do as we're told. And doctors don't like that either. No. So, challenge.
Yes, fortunately, her NG was due to be changed. And they're like, okay, we're going to take it out and we're going to put another one in. And I was like, no.
No, you're not.
You need to give me 24, 48 hours with no NG to see how I do.
Yeah.
Because I'm never going to...
for you.
I'm never going to... But it worries me because actually I had the mummy bear balls, and I'm also a healthcare professional, so I did stand up and say no. But it worries me that there are other mothers who wouldn't or didn't feel like they could.
Because you think the doctor knows best.
If doctor says we need an NG, we need it.
Yeah.
You know, and there was a mum whose little one had been in, she was very, very premature, but she'd been in for ages. And she basically said that, her breastfeeding journey was just destroyed.
Yeah.
Because
they just kept topping up.
They just kept topping up. Yeah, I did stand up and say, right, no, you need to give me a chance to actually do this.
Yeah.
Barring a tongue tie, which was fun. I did it.
Good.
She didn't lose that much weight, which is obviously a worry when you first start breastfeeding. There's obviously an initial dip and then it's getting it back up.
But you did good.
But we did it. And fortunately, my neighbour and friend is also a midwife. Handy. So I even like blackmailed her. I was like, right, the only way I'm getting out of here is if you promise to weigh her tomorrow for me. So I did it, and we got home. I missed my daughter's first day of school, but I was home sort of for the second or third day, which was amazing.
Yeah.
But we were home on day 22.
Oh, what a journey!
Which, given that we were told up to sort of a year, was...
Yeah, tell us about that.
Which was insane. We were very, very happy. But then again, it's the holy, I'm at home and I have nobody.
Yeah.
What if something happens? Before we were allowed to go home, they made us watch infant CPR videos.
Yeah.
Which... Not only am I already aware that she's very poorly and at risk of becoming very poorly, to actually have to watch a video and be told I have to before I'm allowed to leave.
Yeah.
I'm like, is this going to happen? Am I going to have to perform CPR on my baby? It was.
It's one of those things you hope you never ever need, and you don't want to learn it because you don't ever want to need it, but you
especially when it's your own baby. Yeah. So I mean, I'm glad they did, because obviously had the worst happened, at least both myself and my husband would fully versed.
To do, yeah.
But
yeah,
the prospect of that was like, oh, what's gonna happen?
So what is life like or expected to be like for Indy now?
So we've had a rough first couple of years. Her first winter was awful. As with most newborns, winter is always troublesome. But she caught RSV.
Oh no. I was hoping you wouldn't say RSV.
Yes.
Ladies, please get your RSV vaccinations. It is on the rise and it is absolutely awful and increases the risk of if babies get it, increases the risk of pneumonia and bronchiolitis as well, which are just respiratory conditions. And with a CDH baby, you definitely don't want any of that, do you?
No. So she did get RSV and bronchiolitis.
Oh.
I just missed out on my vaccine because of when she was born. She was born in August.
Yes, so they'd only
so like another couple of weeks, and I would have got it. She was really poorly. Like at one point, I made them get a chest X-ray because I was convinced that she'd re-herniated. She was breathing so badly. It was oh my god. We were then admitted by blue light to Great Ormond Street on the 27th because they thought she'd reherniated.
Oh, baby.
Oh, baby. But now that they've fixed that hole, no surgeries on the horizon at the moment. We're just on sort of 6 monthly monitoring, still under Great Ormond Street. They're amazing. And her consultant is lovely. Yes. But yeah, no surgery on the horizon at the moment. But we don't know. There is a risk of reherniation. And they don't know why or when or how. It might happen, it might not. But she is small, but she's proportionate. They're not worried. Developmentally, she's doing okay. She's walking, she's shouting. She doesn't have any actual words yet. Yeah, very loud. So we're just going to keep an eye on that.
She said water. I feel like I heard her say when you said water, she sort of mimicked you, and I was like,
a bit. We're getting some potentials.
Yeah.
We've got sounds. We've not got words yet.
Yeah.
But yeah, she's doing amazing, all things considered. I consider, like, I've joined a parent group for CDH children, and I see some of the stories of these children who've gone home on home oxygen are still peg fed or NG fed.
Yeah.
So the fact that we've gone home with seemingly no extra care, she did have horrific reflux and constipation,
which is more common as well.
Yeah.
For CDH babies. Yeah.
But otherwise, touch wood, we are doing so well.
Amazing.
But yeah, it's just taking it sort of each day and each month at a time to see what happens, and hoping it doesn't happen, but being ready if it does.
Thank you so much for sharing your story. I think a couple of key points I just want to kind of use to bring us to a close is like how you talked about advocating for yourself. Like if you think something's not right, you don't know what it is, because you may not be the expert in, you know, conditions of pregnancy or anything like that, but you are an expert in your body.
Yeah.
So you know what your body normally does, what you think it's supposed to do, and you just have that sense when something's not quite right. So definitely stick to your guns with that. Ask for healthcare support. Keep escalating if you don't feel that you've got a satisfactory answer that makes you feel listened to. You can go through things like PALS, so that's something really important that you can use. Like where you talked about when she was in surgery, there was some times where you wanted to kind of raise concerns. Like you can also look into Martha's Rule. Martha's Rule is there to be able to help if you've got concerns about the well-being of a family member. You can ask for a second opinion, a second referral or a review, of the care. So it's so important, everyone, to just kind of be bold, advocate for yourself, learn about things like that. So I imagine you did a lot of research.
Yeah,
I can imagine to really understand and know about this condition so that you could do everything that you needed to do for Indy's best interest. So yeah.
But make sure you've got someone to talk to, because everybody deals differently. I did struggle because I like to talk. I like to talk it through. Okay, if this happens, we're going to do this. If this happens, we're going to do this. But my husband deals differently. So for his own coping ways, he only wanted to talk about the actual facts that we had. He said, okay, well, we know A, B, and C. Let's not worry about D, E, and F until we've actually been told that they're a problem.
Yeah.
But that's not how my brain works.
No.
So if you do have a partner who, for their own reasons, because like I said, that's how he copes.
Yeah.
And it wasn't for me to say, well, no, you've got to do what I need to do. Find someone who you can talk to.
Yeah.
So my mum was obviously a great support, but I was advised ARC.
Yes.
Ali did.
This is one of their information leaflets. So I was going to mention them as well. Yeah. So perfect. Yeah. ARC.
Because they are
antenatal results and choices, and they basically will support you in the process of decision making, understanding as well, and just like signposting to where you can go to for really good information.
Yeah. So just make sure you have somebody that you can talk to in whatever way you find beneficial. If you want to talk to the midwife, if you want to talk to the consultant, if you want someone completely impartial like ARC, if you do have a partner whose brain works in the same way as you, obviously talk to them. It's very hard for partners as well, because they aren't the one going through a lot of what's happening. And they do tend to bond at different points as well. Like, you know,
Yeah.
obviously not with this one because obviously I knew something, but most women start bonding with their baby the second they find out they're pregnant, because you can feel the movements, you feel sick, you've got all the hormones associated with. A lot of male partners mostly, but female partners obviously do as well, or even sort of non-binary. But if you're not the one who's actually carrying the baby, it can be hard to feel as connected or as bonded.
Yes.
So they may struggle more or differently because they're not going through it physically. So it's important. In my unit, obviously, we've got the Miscarriage Association that we're very heavily linked to and signposted to. They have specialist partner support.
Amazing.
So, and I'm sure ARC would be very happy to have a partner of a mother who needs specialist support or a sounding board or just something. But yeah, make sure you look after each other because you're going through it together.
Yeah.
It's their baby as much as it's yours. You know, it's not one person or the other. It's not one person's decision. It's a group decision.
Yeah.
But yeah, it's not always bad. You do sometimes get a crazy little nutter like this.
You do, and aren't we happy for that?
Most of the time. 3 a.m, maybe not.
Less happy.
Less happy. But yeah.
Well, this has been amazing. Thank you so much for sharing your story with us. And yeah, it's amazing to see how far Indy's come. Well, ladies, if you are going through anything like that, you feel free to reach out. We, you know, I'm always happy to engage with women. I offer birth reflections as well. But yeah, antenatal results and choices. If it's specifically CDH, then go to CDH charity. If you've got a specialist midwife who is involved in your pregnancy care, then reach out to them. We, as a specialist midwife, I know we always will make as much time as we can to provide as much support as we are able to for women, and even just being a sounding board, just talking to someone who understands or at least can relate to that can help. So yeah, I hope this has been helpful for you. This has been amazing for me to learn so much about CDH.
I mean, if anybody does have an antenatal diagnosis of CDH, you've obviously got my number.
Yeah.
If Dede wants to pass my details on to anybody who wants someone who's actually
been through
the same situation, because locally it's not necessarily something that you encounter.
Yeah, you don't come across it very often.
So
yeah. Amazing. Thank you very much.
Thanks for having us.
Like, subscribe, and we'll see you for the next one.
Bye.